All right, so the topic for today is where lung lesions hide. And in some respects, this is going to be the one of the most important conferences that you get, in the sense that there's not going to be a quiz for what we're going to go through here, but the objective is to avoid you from taking a quiz at a deposition of a plaintiff's attorney. So that's the idea here, hopefully. So one of the most important things is what you see is affected by the context. So if you look at these, right, doesn't the color of these squares look different than the color of these squares? But I'll tell you that they really are the same color. It's just that what is surrounding them makes them look different visually to you. Uh, some of these optical illusions that I like, or these puzzles, is the red dot on the near far corner. If you stare at it, it seems to move back and forth between the near corner and the far corner. And so in radiology, we're in a very perceptual field. Uh, how many legs does this elephant have? If you start counting the legs, they seem to move around on you. So, where are the legs? Start counting them, and they kind of move around, right? This is one of my favorites. Are the circles moving? I mean, sure, they look like they're moving, right? So here, and then on the next one, it looks like they're getting bigger and smaller. But if I put the pointer there, you'll see that they're really not moving, right? So these are some nice optical illusions. So how does this come into radiology? Well, if you look at this radiograph, right, is this a pneumomediastinum? There seems to be that lucency alongside the descending thoracic aorta, and we do get calls from referring physicians that see stuff like this, and they ask if that's pneumomediastinum. The interesting thing is, if I just cover that edge of the aorta, right, that lucency seems to disappear, right? So what is it that we're looking at here? What do we call it? This is a mock effect, right? And if you recognize that when at the edge of a structure, especially when there are changes in attenuation or density on an X-ray, that you can have these mock effects, that you can recognize that that's not a pneumomediastinum, that's just a mock effect. And it comes up sometimes, from the ER, they'll call us and they'll ask us if that's a pneumomediastinum next to the heart. This is a common location where it looks like there's lucency next to the heart, but because of the pulmonary artery there and the density at the edge of the heart, sometimes people mistake that for pneumomediastinum. But as a radiologist, you kind of recognize that's just some optical illusion, if you want to put it that way, and it's not really pneumomediastinum. One of my favorite expressions is you see what you know, right? So if you know about the Mach effect, then that's a Mach effect. If you don't know about the Mach effect, then that might be pneumomediastinum to you, right? And this is true for everything that you interpret, right? The type of pathology that you will be interpret is based on what you know. So that's why it's important to do a lot of reading and studying and get to know as much as you can in this field. So we know a little bit about this. Also, we've gone over this, trying to differentiate pneumothorax from a skin fold. So we look for the Mach effect, and that can help you to differentiate a pneumothorax from a skin fold, right? So these are things that hopefully you learn as you're going along. So if we look at this chest radiograph, the abnormality on the chest X-ray, why is this patient short of breath? Because they have what? What is all that? What? Yeah, so they have a consolidation there in the right lung. Okay, so they have a pretty bad consolidation in the right lung. Are we done, or is there something else that we need to notice?
There's a tooth in the bronchus.
Yeah, there's a tooth in the right main bronchus, right? How easily that can be overlooked. Okay, so it's important. If you've never seen a case like this, right, you're likely to miss it. Now that you're familiar with that, if I show you this, where?
In the left main.
Yeah, there's another tooth in the left main bronchus, right? So we're used to, on radiographs, kind of overlooking all these densities that are over the chest because, we look through the leads, we look through all these devices that are overlying the chest. But it is still important for you to look carefully, and you want to try to account for densities that, don't quite fit into your understanding of what you're used to seeing. And so this is where we get into pattern recognition, is that you learn from your prior experiences the appearances of abnormalities, and a good radiologist remembers the patterns, right? So having now seen what a tooth looks like, right, that you hopefully will be able to recognize that in the future. There's also a difference between active and passive observation. If I ask you if this is a spiral pattern or are you looking at a series of circles, well, just passively, as you just kind of look at that, it looks like a spiral. But if you look at it actively, where you actually trace it around with your eyes, you will see that each one of these is really a separate circle. So that's the difference between active and passive observation. And it's very easy for us in radiology to get into the mode of passive observation, especially when you're looking at CTs, where you're scrolling through those hundreds of images. So what you do is you're just sitting there scrolling through images, and you can easily become unconscious as you're doing this, or subconscious, and you're looking for something to tick off, your visual filter. So usually you look for symmetry, you look for something that stands out. But it's very important that as you're doing this, that you're stay engaged, that you're asking yourself, what is it that I'm looking for? What am I doing now as I'm scrolling through this? I'm looking at the liver, and then you go back. I'm looking at the spleen, or if in the case of the lungs, if you're looking at lung windows, now I'm looking at the right upper lobe, now I'm looking at the right middle lobe, now I'm looking at the right lower lobe, now I'm looking at the airways. It's very important as you do that to keep prompting yourself so that your mind remains active. And so, it's very easy as you scroll through this very quickly to miss a small nodule like this, right? So it's very, very easy to skip that as you're scrolling through it. And while we're on the subject of looking for small nodules on CT, I really, really encourage you to use your axial MIPS. So in cases where nodules are important, let's say you're reading it for metastatic disease, in most cases, a 3 millimeter nodule, 4 millimeter nodule is not going to make a difference, trauma CT or CTs for other reasons. But if you're doing a CT on somebody to rule out metastases, then every single nodule can be important. So I encourage you that when you're looking for small nodules, really use the axial MIPS, because as you scroll through that, it is much, much easier to see these small nodules on the axial MIPS, and then you go back and then you can find them on your thin sections. So that's one word of advice. Really use your axial MIPS when small nodules become important, depending on the clinical question you're being asked on CT. Okay, so on this chest radiograph, anything important that we need to mention on this chest radiograph?
Oh, is that fracture?
Where?
The right clavicle? I can't see that.
No, well, I mean, here's the distal clavicle over here. There's the acromion, so the acromioclavicular joint is in the right place. Nobody has anything to say?
It looks like, okay, so if we look at the lines for a second, right? I think we've got like the right central venous catheter,
Yeah.
right jugular guided, jugular guided. Is it a little bit curled up top? It seems
The central venous catheter?
yes. You see like superior.
All right, I'll give you a close-up.
Yeah. I mean,
The ET tube is too, like.
Where's the ET tube?
Not overlying the trachea.
It's in the esophagus.
Yeah.
Here's the trachea. The endotracheal tube is in the esophagus. Okay, so go back to the original film. The ET tube is in the esophagus. All right? So the important thing is to be systematic when you're looking at chest radiographs, right? Remember, what's the first thing we look at on chest radiographs, especially on ICU patients? lines and tubes, right? So you have to look at that first on chest radiographs. So on this chest radiograph, was there anything?
Tear tube in the esophagus. Needs to be put further. Distal esophagus.
Okay, so again, nothing jumps out at me, right? We've talked about this. The important thing is to be systematic. When you're looking at your chest radiographs, what's the problem? Shoulder dislocation, right? And these are common, especially in trauma cases. This patient was in the ICU at the edge of the film. So to be systematic, you look at lines and tubes, heart size, the lungs, look at the bones, the edge of the films, to be systematic in your approach. And that discipline is what keeps you from missing important abnormalities. Okay? The checklist. It's important to develop a checklist for everything, every kind of study that you're looking at. An active observer has a focused, systematic approach. For every type of study you interpret, you should have a checklist. Most of us develop our checklist based on what we missed in the past, which is a good thing, right? Because all radiologists make mistakes. The difference between a good radiologist and a bad radiologist is that a bad radiologist keeps repeating the same mistakes, right? So to be a good radiologist, you want to learn from your mistakes, develop your checklist, and the more thorough your checklist is, of course, you're going to be slower, but by practicing it, you're going to get faster and faster at looking at all those things on your checklist. If you're diligent about practicing your checklist on every type of study that you look at and be systematic in your approach, okay? So here's a lung cancer screening study, right?
Left lobe mass. For left upper.
Yeah, so there's a mass here, right? Where is that? Yeah, so there's a mass in the lingula. Okay, tumor in the lingula. Maybe some other nodules, some pleural thickening, some funny looking stuff. Oh, somebody said what? Yeah, here in the left upper lobe bronchus in the airway. As we go down, there's a big honker in there, right? There's a big tumor in the bronchus there. So this patient has more than one site of cancer. There's cancer in the left upper lobe bronchus there, and also there peripherally in the lingula. It's important when you're looking at CTs to add the airways to your checklist. When you're done looking at everything, I like to actually look at them first. When I'm looking at the lung windows, I like to scroll through the airways first before I look at anything else. But make sure that the airways are included in your checklist. Scroll through the lung windows very carefully, just looking at the airways, because these airway lesions, it's been shown in studies that airway lesions are the types of lesions that are commonly missed on CT scans, okay? So it's important to add the airways to your checklist and to look at that. Now, having said, we've talked about CT a little bit, the rest of this, we're going to talk about plain films, what you need to know about plain films, okay? When we look at this x-ray, anything wrong? Nothing? All right, so you're a little bit looking at that. Anything else?
It looks like the descending aorta is a bit distant.
There's a tortuosity of the descending aorta. That worth calling a referring physician about?
Not really.
Anything else? Okay, how about now?
That's not a nipple, that's a nodule.
That's a nodule. Well, it's too high to be a nipple, right? Even here, that's a lung nodule, all right? That was cancer, okay, lung nodule. Now, surprisingly, present company accepted, we're usually pretty good at this, right? We're usually pretty good at finding these nodules in the middle of the lung that are surrounded by air, right? And granted, it's a lot easier to see this on a packed workstation when you're looking at the big X-ray in front of you than in a PowerPoint presentation. But generally, we're pretty good at this, sometimes too good. I mean, when I sit with first-year residents, they point to a lot of things that, look like nodules that turn out to be nothing. But generally, these are pretty good. When you're reading a study, sometimes you look at a chest X-ray and there's an obvious mass here, I mean, that's a cancer. Your first reflex is to pull out the prior study. And, if you're a chest radiologist, you're hoping that you did not read the prior study, right? And then you look at it and you wonder, was it there 1 year prior? You look 5 years prior. So 5 years prior, there's nothing there. Now there's something there. Was there something there a year ago?
Yeah.
There was, right? There was something, but that's very subtle, right? That's pretty subtle. This we're usually not very good at. So nodules that are like that near the hilum, especially very early on, there's a lot of noise from the hilum, from vessels overlying. So these types of nodules are easily missed. Nodules out in the periphery, though, we usually see. These we're not so good at finding those. But don't feel bad if you miss something like that. Feel bad if you miss something like this. So these are the type of errors that I'm trying to help you to avoid, right? What do we see here? Where?
Right apex, right
Yeah.
upper lobe.
Right here in the right upper lobe. There's a mass. Okay? Now, if I point it out to you, you can see it fairly easily, right? There's a mass there, lots of difference between that and the other side. So that's a pretty large lung cancer. So these are the type of abnormalities that you really don't want to miss. So the objectives for this talk is learn about the blind spots on a chest radiograph, develop an approach to evaluate them and to avoid the mistakes of a novice or the inexperienced when you're looking at chest radiographs. So locations of missed cancers. A very nice study was done here by Austin back in 1992, where he looked to see, just plotted out where all of these cancers were missed on chest radiographs. And this was repeated by Charles White in 2009 with a lot more cases. And so these were all nodules or cancers that were missed. And you can see where they kind of all fall on the chest radiograph. You see they kind of cluster over the apices. You see this area here in the perihilar regions, not so much in the mid-lungs, but this area up here, these areas here are the areas where you really want to take a careful look at on your chest radiographs to avoid missing cancers. And so one of the ways I have of interpreting this is these are the areas you want to concentrate on or take a second look after you're done with reading the chest radiograph. When you're ready to put it away and sign your report, go back and take a second look at these areas to make sure that you're not missing anything. The upper heart, the upper part of the chest here, this area that looks like a heart here is diagrammed out. Look for symmetry, compare one side to the other so that you don't miss anything in the apex. The right paratracheal area, the aortic arch, the AP window, the hyla, the mediastinal lines, the azigoesophageal line, the paravertebral line, retrocardiac regions, and the diaphragms. Add these areas to your checklist. Go back and take a look at this before you put the case away to make sure that you're not missing anything. Okay? Up here, look for symmetry when you're up there. So now that we know the game, when you're looking at this chest radiograph, what do we see?
Right.
Yeah, so there's an obvious mass here, right, in the right apex. So that's a cancer. What about this one? Again, in the right apex, when you look for symmetry, comparing this side to that side, right? And then what helps is when you pull out the prior chest radiographs, really, really encourage you, if you find an abnormality or something that you're questioning, go back and look at your priors. Right? So you look at this and now you compare your prior chest radiograph. There is a real difference there, okay? So this is real. And one of the few cases where a lordotic view is helpful, but anyway, there it is. That's a cancer. This guy.
Left apex.
Yeah, right. Easy now. Now that you know, you look up there and you compare one side to the other. Okay? Big tumor in the left apex. Always surprising how much worse these things look on the CT than they look on the chest radiograph. Okay? What about this one?
Left apex again.
Left apex?
Left
It's
side.
like a-
Yeah.
Just very
Yeah. Right here next to the aorta, right? There looks like there's something there. Again, you pull out the old study, right? So if you're questioning something here, compare it to what it looked like 2 years ago. Now there's an obvious difference, right? So that's another cancer, and 3 months later, it got even bigger, right? It's an obvious cancer there. The right paratracheal line. So the normal right paratracheal line is about 2 millimeters thick. You can see it through the shadow of the superior vena cava. And then this guy down here, what's this guy down there? What's that oval thing? Is that lymphadenopathy? What is that? That's the azygos arch. That's the arch of the azygos vein. Okay. On a good PHS radiograph, you can see all of these things. And the reason we see the right paratracheal stripe, you have air in the trachea, you have air in the lung, so you will see that stripe very nicely, even superimposed over the shadow of the superior vena cava on the chest radiograph. So on a PHS X-ray, we want to include the right paratracheal stripe, that right paratracheal region, in the areas of what you want to look at. So a normal right paratracheal stripe. Okay. So here's the current X-ray you're looking at. Here's an X-ray 16 months prior.
Opacity. Right.
So here we can see a right paratracheal stripe. Okay. Here's the shadow of the superior vena cava. Now we don't see a right paratracheal stripe, and it looks like there's widening in the right paratracheal region. So the most common explanation for that would be what? Lymphadenopathy, right. So this patient has right paratracheal lymphadenopathy. Okay. Anything about this one?
Right.
So you're wondering about the right paratracheal region. What are you going to do?
Look at prior.
No. Yeah, first thing you're going to do is you're going to pull out the prior study. And what do you think comparing it to the prior study? Actually, you should always have the prior study out anyway, right? But now are you convinced that that's real? Yeah. So that's what it's supposed to look like. You can see the right paratracheal stripe. You look at the density there, it is much greater now than it is there. And there's another reason you should have an increased suspicion for lung cancer in this patient. What's the reason? Yeah, he's got emphysematous lung, right? You got bullseye up here. So this patient's a smoker. So that's going to change, right, your sensitivity there for what you're looking for. Obvious tumor. This one's invading the vertebral body. Always surprising, again, how much worse it looks on the CT than it is on the chest radiograph. The aortic knob, left paratracheal region. So the aortic knob, nice and smooth, right? So you want to include that area in what you're looking at on your checklist. It should be very smooth like that. What's wrong here?
You don't see the contour of the aortic knob?
So what are you going to do?
Prior.
Pull out the prior, or take a much more careful look at it. Now, are you convinced that it's real? Yeah. So this is what it should look like in this patient. And now it's somewhat obscured, fuzzy. There's extra opacity in there. The AP window is not as clear as it was on the prior study. Cancer with lymphadenopathy in the AP window. Okay. What about this? You worried a little bit about the right paratracheal stripe? Anything else you're worried about? The left paratracheal stripe?
Very worried about lymphadenopathy.
Well, let's pull out the prior, right? Prior chest X-ray.
There's more lymphadenopathy next to the knob.
Next to the knob, there's this density here that was not there before. See it? Okay. Cancer. All right. The aortal pulmonary window. So normally, so you have the knob, the aorta here, the arch of the aorta, you have the left pulmonary artery. Here, there's usually an indentation like that, that can be concave toward the mediastinum, or it may be straight towards the mediastinum, but there should never be anything bulging out from the AP window. The AP window is that area between the undersurface of the aortic arch and the left pulmonary artery. Include this in your checklist. Always look at the AP window. Make sure there's nothing bulging out from the AP window. That's usually aortal pulmonary window lymphadenopathy. So here on coronal MR, you can see where the aortic arch is. There's the pulmonary artery. You usually have some fat in there. Okay, there's the AP window. You should not have anything bulging out from the AP window. Here's an example with lymphadenopathy, right? Bulging out from the AP window. So it should never be convex. If there's something bulging out from the AP window, you have a problem, okay? And this is an area that's easily missed unless you include that on your checklist every time on a chest radiograph to look at the AP window. So here's the prior chest X-ray. Here's the current chest X-ray. What do we see?
Capacity in the AP window.
So here's what the AP window should look like in this patient. Now there's something bulging out from the AP window. Very subtle, but it's real. Lymphadenopathy. This is from cancer in the left upper lobe bronchus that's metastasized to the aortal pulmonary window. Okay? AP window lymphadenopathy can be very easily missed on the chest radiograph. The hyla. The hyla should be smooth and vascular. All right, so you should have very smooth hyla. So you want to include that on your checklist, looking at the hyla. What do we think of this?
Left perihylar opacity.
So there seems to be increased opacity here in the left perihylar region, right? 6 months later, big cancer, much bigger, okay? How about this case?
This isn't right,
The right
very
area.
high.
So what are you going to do?
Look at the priors.
Pull out the priors.
Ooh,
Okay, that's
Now are you convinced it's real?
pretty.
So that's what the right hilum is supposed to look like. Now there's something there, okay? Again, it's cancer around the bronchus, right? What about this one?
Left.
So somebody says right, somebody says left,
bilateral.
huh?
Is it bilateral?
Bilateral? So what are you thinking about?
Sarcoidosis.
Okay, so both hyla look a little lumpy in this particular case, right? This is a patient with
Sarcoidosis.
sarcoid. Yeah, this person has bilateral hyalurolymphadenopathy. He also has subcarinal lymphadenopathy. So this is a very lumpy looking hyla. This is a patient with sarcoid bilateral hyalurolymphadenopathy. Because it looks symmetric, you know, you can miss that. How about this?
Is there opacity?
It's on the right, I'm trying to figure out what line that is.
You worried about the right? Right what?
Anterior mediastinum,
You're worried about the anterior mediastinum. Why are you worried about anterior mediastinum?
is that a Highland overlay sign?
Where?
There's like a bulge
On what side?
on the right.
On the right. Oh, I mean, here's the hilum on the right. I don't see anything over it. Nobody sees anything on this chest X-ray? Okay, how about now? What side do you think the abnormality is?
The left.
Okay,
Sorry.
do we see anything?
It's a very small, radio opacity of like the left hilum, maybe.
Nobody sees anything. How about we look at other things besides the hilum?
Is it the AP window? It's a little bit, maybe bulging convexity.
Nothing?
Oh.
Rib fracture?
I said no, rib fracture.
No rib fracture. No rib fracture. Really?
Oh, come on.
That rib's destroyed. There's a
Ah,
tumor
jeez.
here. Okay? One of the most important rules, the blackness of the lungs should go to the edge of the ribs. Go back. That's true in the apices. That's true along the lateral aspects of the chest. The blackness of the lungs should go to the edge of the ribs. You look here, there's something here. Okay? Now you look carefully and you'll notice that that rib is missing. It's destroyed. Right? This is, in this case, it was actually multiple myeloma in this particular patient, but it could easily be metastatic disease, could be a tumor growing into the rib, right? There's something there in the chest wall. The blackness of the lungs should go to the edge of the ribs. Remember that when you're reading your chest x-rays. How about here?
Right pleural
Yes,
opacity.
there's a right pleural mass here. Okay? So look at the close-up. There's your right pleural mass. The blackness of the lungs should go to the edge of the ribs. What does this mass turn out to be?
That looks like it's fat density.
So what is it?
Is that hematoma?
No,
Lipoma.
it's a lipoma. It's a pleural lipoma. So it's okay for this patient. But the point is, the blackness of the lungs should go to the edge of the ribs, and that's how you will avoid missing masses in the apices and missing masses along the lateral chest wall. That's the first thing that clues you in, and then as on that prior case, once you notice there's something there, you go back and look very carefully at the ribs to make sure you're not missing rib destruction. Okay? So we've talked about the infrahilar window before. This lucency here is what?
Beyond.
What is that?
Bronchus.
Bronchus. Which bronchus is that?
Right.
The right bronchus is higher.
Oh.
That's the left main bronchus, sometimes the left upper lobe bronchus. All right. This is the infrahilar window in here. Usually a clear area on a chest radiograph. You have a vascular structure that goes up and over the left upper lobe bronchus. What vascular structure is that? Left pulmonary artery. Yeah, the left pulmonary artery goes up and over the left upper lobe bronchus. Anterior to it, you have superimposition of the main and the right pulmonary artery. So you have vascular structures surrounding the left upper lobe bronchus, except in this area here. That's the infrahilar window. This line that I'm pointing to right here, what is that line?
That's the wall, anterior wall of the bronchus intermedius?
No,
It's a pleural reflection, right?
no. What is this line? Well, there's a bronchus here. See it? That's the anterior wall of this bronchus. Which bronchus is that?
Left inferior.
Left. There's a left
Left lower.
anterior bronchus? No, that's the left lower lobe bronchus, right? That's the anterior wall of the left lower lobe bronchus. This is the infrahilar window. Okay? Sometimes the vessels are prominent, right, going around the left upper lobe bronchus, and you get what looks like a donut or a bagel with a bite out of it. The bite is the infrahilar window. That's a normal finding. Okay? You should not see donuts, right? If you see donuts or bagels on the lateral view, that's a problem. Usually means you have subcarinal lymphadenopathy. Okay? So in this patient, looking at the x-ray, the frontal view, anything bothering you?
Left hilar.
You worried a little bit about the left hilum? You like the right paratracheal region? Plus, minus? I don't know. I don't see a good paratracheal line there. So let's pull out the lateral. And what do you see? Donut. There's a very nice donut sign here. Okay? So, what do you think this patient's underlying disease is?
Sarcoid.
Sarcoid, yeah. Paratracheal, hilar, subcarinal lymphadenopathy. This is a patient with sarcoid, subcarinal nodes, right paratracheal nodes, also some hilar nodes. Patient with sarcoid with a very nice donut sign. Okay. How about this one?
Again, like subcarinal lymphadenopathy with, looking at the left hilum, maybe some left hilar lymphadenopathy.
Yeah, so there's this abnormal opacity here over the left hilum. There's a nice donut sign over there, so there's something wrong here, right? So this patient needs to go to CT. It turns out they have a tumor in the lung that's actually projecting over and giving you that donut sign. But still, the donut sign abnormal, okay? And so this patient needs to go to CT. Mediastinal lines. We want to look at our mediastinal lines. Is there any mediastinal line here that bothers you? The azigoesophageal line. So we look at the azigoesophageal line. There's a little bump in there, right? So what compartment is that? That's the middle mediastinum, right? So there's a mass here in the middle mediastinum in this particular patient, right? There's a subcarinal mass here in the middle mediastinum. And in this case, this actually turned out to be lymphadenopathy. The subcarinal mass in the middle mediastinum. Any line bothering you here? Let's be fair. Let's give you a better view. There we go. 3 months prior, current X-ray, current chest X-ray. Which line bothers you?
Right.
What line? Right what?
Posterior spinal.
Right paraspinal. Paraspinal line, right? So here's the descending aorta over here, okay? If I go back here, you can see the azigoesophageal line in here, that's okay. But over on the right, here, on the right side, there's a bulge here, right? That wasn't there before. That's the paraspinal line. Now there's a bulge in it. What compartment is that? Posterior mediastinum, right? This was a rare case of posterior mediastinal lymphadenopathy in this patient. Anything wrong here? Any line that bothers you?
The diaphragm's irregular on the right.
I think it's within the range of normal.
Is it right paraspinal?
Where's the right paraspinal line? So, what line is this?
Aortic.
That's the aorta, right? This guy here is,
Posterior.
what line is this? Well, the abnormal line is out here, right?
Yeah. Yeah.
You mentioned it. This is the ascoesophageal line. This is the, what did you say it was?
Right, paraspinal.
That's the right paraspinal line. There's bulging in the right paraspinal line here, going all the way down, right? So what compartment?
Posterior.
T2 weighted MRI, gadolinium. What is it? What? Who said it?
Could be like an inner sheath,
A what?
like a paraganglioma, like an inner sheath, right?
Okay.
Side of the cancer.
Well, what's the signal characteristic on T2?
It's hot.
Intense.
Not hot, but very bright, right? So it's hyper intense on T2. Enhancement with gadolinium,
Yes.
much enhancement with gadolinium. So what's bright on T2 and very vascular? You mentioned, yeah, paragangliomas can do that. What other tumors can do that? If it's in the liver, what would you call it?
Oh, meningioma.
Hemangioma. This was a posterior mediastinal hemangioma. Okay, those can also be very bright on T2. You see that slow growing. You see a little bit of erosion on the vertebral body there, so it's a slow growing benign tumor. Blind spots. There are certain blind spots on the chest X-ray. Anybody see anything here?
Yeah, the right, like near the right hemidiaphragm.
Yeah, over the right diaphragm, right? This area over here.
Yeah.
Ooh.
That's a blind spot. That's easily missed. Heart and the diaphragm, looking behind the heart, looking over the diaphragms. Those are blind spots on the chest X-ray. Big tumor, right there, right? How can you miss a 4-centimeter tumor on a chest X-ray? It's over the diaphragm. This one,
Oh, yeah, he's missing.
where's this?
It's adjacent to the, it's like a retrocardiac, left
So,
lung base.
Let me give you the prior, right?
Yeah.
So that's what the retrocardiac region looked like before. That's what it looks like now, right? There's a mass in the retrocardiac region. So you want to look behind the heart. Another cancer, left lower lobe. This one, this one's really tough, but there's a little tiny nodule right there, right? So this was another tiny, small, look at that, small nodule right over the heart. Okay, that's a tough one. The lateral view, right? What do we see in the lateral view on this one?
Nodule.
There's a nodule, and for whatever reason, this nodule you can only see on the lateral view. There it is, over the heart. You have to explain, what is that? Well, there it is. It's a cancer right over the heart, projecting over the heart on the lateral view. Okay. Neuroforamina, look for your neuroforamina. On your lateral view, look at the neuroforamina, right? They should be lucid. Also make sure that you look at both diaphragms, both posterior diaphragms. You want to see both diaphragms posteriorly on your lateral view. You want to see the neuroforamina on your lateral view, okay? This is a patient who has a large left shoulder mass. Do you see the left shoulder mass?
Yeah.
Oh yeah, can't miss that thing. Right there it is. Is there something else?
The spinal, white spine sign.
White spine sign?
Spine sign.
Okay. Yeah, well,
Opacity.
you look at, there's an opacity here right over the neuroforamina, right there, okay? Now go back to your frontal view and look very carefully. Tell me if you notice anything.
Like left mid lung.
There's a vague left mid-lung opacity here, right? There's the opacity over the spine. There's this vague opacity over the left mid-lung. And what else do you notice about that? What?
It's like a running the rib.
Yeah, the rib is missing.
Wow.
You see this rib, right? Don't see the rib here. That rib is missing, okay? Big metastatic lesion in the rib, projecting over the neuroforamina. So you want to look at that on your lateral view. Once you notice that, you go back and take a much closer look. And now you see that vague opacity and you notice that the rib is missing. But of course, you include the ribs on your checklist of things to look at, right? This one.
left lung base.
Do we see anything on the lateral view?
Yeah, right at the neuroforamina.
Yeah, so you notice this neuroforamina is nice and lucent, this one is lucent, this one is different.
Oh,
There's a mass here. Okay,
that's,
cancer projecting over the neuroforamina in the left lower lobe. This one, somewhat more obvious. We have a mass over here. You can see on the lateral view, there it is projecting over the neuroforamina. There. These are more lucent than that one. Tumor in the right lower lobe. This one's somewhat more subtle. When you look at the neuroforamina on the lateral view, do you notice anything?
Yeah, inferiorly, you see
Yeah, so we'll
acid
pull out the
below
old
diaphragm.
films, 4 years prior. That's what the neuroforamina looked like before. That's what it looks like now. Cancer. How about this? Now, you brought up a sign, right? What sign did you mention?
spine sign.
The spine sign. Is there a spine sign here?
Yeah.
There is a spine sign. And also, it is very important to look for both posterior diaphragms on the lateral view. Do you see both diaphragms on the lateral view? Especially posteriorly. Which one's missing?
Right.
The right. So what are you going to do now?
Look at the frontal to see.
Look at the frontal, and do you notice anything?
The opacity right over the right diaphragm.
There's an opacity here, right? And this diaphragm, that right diaphragm back here, is obscured. There's a spine sign, right? So there's something going on where? What lobe?
Right lower lobe.
Right lower lobe. Always look for both diaphragms, both posterior diaphragms on the lateral view. You'll pick up small pleural effusions, you'll pick up pneumonias, you might pick up something like this. What is it? Anybody know what it is?
Sequestration.
What?
Sequestration.
Why?
I think it's long and artery from the,
Oh.
Yeah, there's a consolidation here, right? Some mass-like consolidation, but there is a blood supply coming from the aorta, the abdominal aorta in this case, going up to it, which tells us that this is a sequestration, right? That's a sequestration. So here's a reconstructed view showing the blood supply from the abdominal aorta going up to this mass here in the right lower lobe. That is a sequestration. This patient had a history of recurring pneumonias, and it turned out because of this sequestration there in the right lower lobe. Use an organized scan pattern. I would encourage you to develop your own scan pattern and apply it consistently. Use the same scan pattern on all your x-rays. Use the checklist. So approach them the same way, and that way if you apply your checklist, you will get faster and faster, but you will include everything and be systematic about what you want to look at. We've covered all these areas of things we want to look at on our chest radiograph. We talked about looking at this area up there for symmetry, looking along the hyla, looking at the paratracheal regions, the AP window, the diaphragms, retrocardiac region. Remember, the blackness of the lung should go to the edge of the ribs, especially along the apices and along the lateral chest walls. Okay? We talked about the infrahilar window, donuts, bagels, right? Donuts are not good on the lateral view. Donut sign, something's wrong. Okay? Posteriorly, you want to see both diaphragms. Look at the neuroforamina. Make sure that one does not look more opaque than the others. Otherwise, you need to come up with an explanation for that. Always look for both posterior diaphragms on the lateral view. Okay? A few test cases. Anything here?
Upstate fence.
Yes, right there. Something up there, and you see it on the lateral, by the way.
Yeah.
Right behind the trachea, right up there. There it is. Right? There's something up there. 16 months prior, look at that tracheal region. Maybe, but it looks smaller if it's there. Right? And that, of course, was a cancer. This guy, did we see anything? Highway. We have one vote for Highland, one vote for AP window. Anything else? Well, pull out the old films. And what's the problem? Where? Right paratracheal? Look at the aorta here. Aorta, Aorta.
Window.
aorta. Well, AP window's down here, right? There's something here, left paratracheal region next to the aortic knob. Okay? Big mass. Big mass up there, next to the knob, going up. And it's even worse, of course. This guy.
Donut sign.
Donut sign, big donut sign on the lateral view, yeah. Donuts are bad, right? Big donut sign on the lateral view. So what is this? Yeah, this turns out to be a high attenuation bronchogenic cyst, right? It's in subcarinal mass. This guy?
Right, very highly.
We have one vote for right perihilar. What? AP window. What do you think?
Both.
Both. Definitely, though, the AP window, right? There's something bulging out from the AP window. Definitely abnormal lymphadenopathy. Right? That's AP window lymphadenopathy. Okay? This guy? Spine sign, right, down here. Okay? Something's wrong. 8 months prior, that's what it's supposed to look like. Something is down there this time. So what side do you think it's on?
Left.
Yeah, one vote for right, one vote for left. Right side. Big mess. So that's our discussion of where lesions are. By the way, where's the lesion on this X-ray?
Right.
Where?
Paratracheal.
Right paratracheal? Anybody see anything else? Right lateral lung? It's behind the pacemaker.
Oh, jeez.
Okay? Tricky.
That's mean.
That's me. Okay. Happy hunting. Good. All right, now we move on to the